So my name is Christine Fox, and I am a child neurologist and also a vascular neurologist. So what that means is by training that I did a full child neurology training, and then I did a vascular neurology fellowship. What that means is then my specialty really is pediatric stroke, so stroke in children. And because we know that children with FACE syndrome can be at a little bit of a higher risk for stroke, I got pulled into the community treating FACE at UCSF. And so that's really where my interest grew out of. I was going to talk today a little bit about headaches and migraines, because those, in addition to stroke, can be something that children with FACE syndrome really have a pretty frequent complaint of. But having said that, I am not necessarily one of the headache specialists. I do a lot of general neurology and along with vascular neurology. So I have a good base level knowledge of headache and migraines. And I was hoping that some of our headache specialists in our pediatric brain center could join me today, but unfortunately they had conflicts. So it's me, but I'm happy if we get into really detailed questions to then pass on any questions or try to talk off screen and do anything I can to help with any detailed questions about migraines that people have. So just to get started, general discussion about headache in children. This is a very, very common complaint in all children. So this is not talking, this is just in the general population. By about 15 years of age, between estimates of 57 to 80% of children will have complained of headache at least one time. And for most of the parents on this call, that's probably not going to be something that is very novel information because it's so common. The estimated prevalence of children who are diagnosed with migraine is smaller than that. It's about 10%. But this is probably a little bit of an underestimate because lots of people in the general population, children and adults who have headache, who may have migraines, don't have those headaches diagnosed as migraines. So moving a little bit from the general population to talk specifically about what we know about headaches in children with FACE syndrome. So it's a little bit difficult to say for sure whether kids who have FACE syndrome have headaches more commonly than the general population. We know that because they're so common in the general population, and because those estimates have like a really wide variance, and because they tend to be underdiagnosed, it's very hard to make a comparison. But we do know it's also something that's really common among children with FACE syndrome, and they can have very debilitating headaches. So what we do know about that, there have been a couple of publications, and one of the best sources of information we have was from the 83 families in the FACE Syndrome International Registry, who completed a survey describing the headaches that their children had. And headaches were reported in about 63%. So if you think back to my last slide, that falls squarely into the estimates for the general population. I should also bring up that there is a possible bias. It's possible that people or families in which headaches were a problem, they might have been more likely to complete the survey. So again, this 63% estimate is really just an estimate.
No, I just want to listen.
And I couldn't tell if someone was trying to ask a question there. Okay, sorry, I thought I had heard, thought I had heard a question. So looking a little bit more detailed into the headache survey from the FACE Syndrome International Registry, the median age at headache onset in the children that were reported on there was about 4 years old. So pretty young, a little bit younger than I think what I typically see in our general neurology population when we're treating kids. The headache can be pretty burdensome. And in what was reported in the survey was that at least 53% had more than 20 headaches over their lifetime. And almost half had a headache, 44% had at least one headache in the past month, and about 4% were experiencing daily headaches. The survey really wasn't sufficient to specify a diagnosis of migraine specifically, but many reported that the children that in their families who had headaches had a lot of migraine symptoms. And when I think of what I mean by migraine symptoms are some of the things that we use in the diagnosis of migraine. So along with the headache, the presence of nausea, vomiting, photophobia, and phonophobia. So I'd like to take a step back. I think that probably many people on this call are familiar with the idea of a migraine. I'd like to talk a little bit about how do we actually diagnose that? What are the diagnostic criteria of a migraine? So what's the difference between a migraine and a regular headache? Most people think that a migraine may be just a very, very severe headache, but there are actually specific criteria that we use in making this diagnosis. And it's slightly different if we think about migraine with aura or migraine without aura. So migraine without aura is listed here, and there are 5 criteria that need to be filled. And the first one is you have at least 5 attacks that fulfill the criteria for migraine. So after you have your first bad headache, second, third, even if they do ultimately end up meeting criteria for migraine, we really don't make that diagnosis until we know that it's something that is repeatedly happening. Headaches, headache attacks each last 2 to 72 hours, so pretty broad range. Someone can have a migraine for up to 3 days. What we do know about children that is a little bit different than this is that some children who have migraine can have very short headache attacks, so really under that 2-hour mark, that only as they grow older do they evolve to meeting this full criteria. Each of the headaches have to have at least 2 of the following characteristics. One is unilateral location, and that's very classic for adults with migraine. It's again a little bit different in children. So children are much more likely to complain of a bifrontal headache, so headache on both sides of the head and really in the front, rather than unilateral on one side. So that unilateral location, again, is a little bit softer in children. Number 2, a pulsating quality. Number 3, at least a moderate or severe intensity. And 4, aggravation or caused by routine physical activity. During headache, so now criteria D, during headache, there have to be at least 1 of the following, nausea and vomiting, or 2, photophobia and phonophobia. And just to be clear, what that means is that so literally fear of light or fear of sound, and how that usually manifests is that bright light really hurts you when you have a migraine, or can make the headache worse. Sometimes it can bring on the headache. And then phonophobia, loud noises really disturb you or can be actually painful when you have the headache. They make the headache worse. And then finally, E, not better accounted for by another diagnosis. And that's to recognize that people can have severe headaches with each of these characteristics when they have other things like, for example, meningitis or other illnesses. So if there is another reason that you're having these underlying headaches, then that does not fit that criteria for migraine. Okay, so that's migraine without aura. And these are the diagnostic criteria for migraine with aura. And what I'm getting at here is what is an aura? And those are simply associated symptoms that can be occur before, during, or after a migraine that are not necessarily simple just head pain, but other neurologic symptoms that can develop. So to fit the diagnostic criteria for migraine with aura, we have the following three things, A, B, and C. A, you have to have had at least 2 attacks. So first of all, you have to have fit the prior migraine diagnostic criteria. And then among those attacks that you've had, you have to have at least 2 attacks that fit the following. So 3 of the 4 characteristics, 1 or more fully reversible aura symptoms. And what that means is that when you have one of the neurologic symptoms that are an aura, that they go away completely. That's not something that sticks around. And just to give some examples of this to make it more clear, some people, when they have their migraines, will have a feeling of numbness or tingling, usually on one side of the body. And that could very classically be tingling, for example, on your hand, and often marching up your arm and sometimes to your cheek. And that sometimes occurs, more typically occurs over the course of minutes and can last up to half an hour before the headache starts. That would be a really classic description of an aura, but it doesn't have to be just sensory, like tingling. Some people will have what they feel like is a little bit of weakness. Many people, for example, may complain of changes in their vision that occur before the headache come on. These are the types of things that we talk about when we're thinking about aura. So 1 or more fully reversible aura symptoms, they go away completely. The aura develops gradually over at least 4 minutes, or they occur in succession, as I was describing, for example, first your hand, then tingling up to your arm, then tingling in your cheek. And this is really to delineate it from other symptoms that can come on really quickly. So for example, if you're having a headache with a stroke, you can have weakness or numbness or tingling, but those come on very quickly, immediately. We wouldn't consider that an aura. We know that the aura symptoms last no more than 60 minutes, and that the headache follows the aura relatively quickly within 60 minutes. And sometimes it may begin either before or simultaneously with the aura. And then again, not attributed to another disorder. And I know that we're holding questions until after this presentation, but I'm happy to go back and then talk a little bit more about how we diagnose migraines. I wanted to spend a little bit of time talking about common headache triggers, because this really is getting into the practical information that I think is most helpful for families who are understanding how to try to take care of the children who have headaches or migraines. And I'm going to use the terms headache and migraines a little bit loosely here because of just recognizing that a lot of kids who may actually fit criteria for migraine haven't actually had that diagnosis. So in general, what are some of the common headache triggers? So kids who have a tendency towards headaches often have a little bit of greater sensitivity or need for regularity within their brain. The things that can trigger headaches that we know are poor sleep, and I think that feels very intuitive to any family member, anyone who has had headaches or someone who takes care of a kid who's had headaches. The interesting thing here, though, is it's not just poor sleep as in they didn't get enough sleep, but it actually can be any change in the regularity of their sleep. So for example, if they're very used to going to bed at 9 o'clock, but one night they went to bed at midnight, even if they get the same number of hours of sleep, that change in the sleep schedule can be a headache trigger. For someone who has sleep as a headache trigger, I think it's important, and we'll get into this a little bit later, to try to maintain a really regular sleep schedule. Another common headache trigger is a skipped meal. And some adults and children can be very, very sensitive to feeling of hunger. People will talk about being hangry, but actually skipping meals is one of the headache triggers that are really common in people who have migraines. So skipping breakfast, skipping lunch, going for too much time in between a meal can be a headache trigger. Inconsistent exercise is another headache trigger. So if you're a person who exercises a lot and then have days without exercising, that change could be a trigger for a headache. Also the other way around, if you're not a person who has been a big exerciser and you jump into a big new physical activity plan, that new change in how much you're exercising can be a headache trigger and make you feel bad. Irregular caffeine use is another one, not so much, I think, for the younger children, but definitely when you get into more of an adolescent age and some high schoolers who are starting to drink coffee or kids who are drinking soda, if you are drinking an irregular amount of caffeine, that irregularity can trigger headaches. Stress, particular emotional stress, can be a headache trigger. Hormonal changes is an important one. And we know that around adolescence, around the time of puberty, is when children really are beginning to manifest some of their migraine characteristics. That's a very common time. In adulthood, especially in women, another common time is around pregnancy. And women who have migraines will report that either the migraines go away during pregnancy sometimes, which is great, or sometimes can actually get worse. So those hormonal changes can actually trigger a change in your headaches in any direction. And it can be very individual. And so it's important for each person to really pay attention to see what their individual triggers are. And some examples for this, odors, food, motion, can be really very, very specific. So I mentioned phonophobia and photophobia. So light and noise being a trigger for headaches or making headaches worse, but some people have osmophobia. So examples for that. I've taken care of one patient who really was sensitive to the smell of coconut. And anytime there was like a sunscreen with a coconut smell or smell of coconut, that actually triggered a headache. So it can be as specific as that. Other people may be very sensitive to a range of odors and have headaches from a pretty broad range of lotions or perfumes, things like that. Certain foods can be a headache trigger. In adults, you'll often hear people say that they've stopped drinking wine, for example, or stinky cheese might be a type of food that causes a headache for them. And then another very common one is motion, like car sickness, airplanes, that can be a headache trigger. And these are things that I think actually are very valuable to spend some time thinking through, because this is going to be one of the best ways to really manage lifestyles in order to manage someone who has frequent headaches. Before I move on, I want to just get back and again reiterate, one of the things here that is consistent across all of these is how important consistency is. People who are prone to headaches or prone to migraines, they tend to be really prone to headaches when something changes. So a lot of lifestyle planning around regularity of sleep, regularity of meals, regularity of exercise, those can be things that can go a long ways in trying to manage headaches. The emotional stress piece, I'm not sure that's anything that we can always manage in our kids to be very, very regular. So it's not perfect, but it is, I think, a pretty powerful tool to have. So based on these, the first things that I always suggest, and these, again, can seem like very intuitive things that people probably do already, but these are some of the most powerful things that we do in order to treat a headache when they happen. So when your child comes and complains of headache, this is the time at the beginning of the headache to recognize, okay, it's time to limit the stimuli. Let them lay down in a quiet room, turn off the lights, let people rest. Sleep is actually a very important headache rescue mechanism. So if it's possible to nap, that can be something that can break the headache. other non-pharmacological or non-medicine things that we can do in order to stop a headache. People describe either hot or cold compresses to the head or to the neck. Massage can be really useful, especially if you have your child resting in a quiet room and you can help massage head or neck, around temples. That can help kids relax. Extra water. So I didn't actually have it on my last slide, but I should have mentioned that that dehydration can be a headache trigger for some people. So making sure that I can see some people smiling. That's definitely something that that I think is relatively common. So having them take a drink of water before they go lie down can be helpful. It's also important to treat early as you can near headache onset, to recognize that's what's going on and to try to cut things off early. One of the things about headaches is the longer that they last, the harder they can be on to break, to break the headache. And I think that many people have the idea that they just want to, power through it. And I don't want to interrupt my day. This is something I can handle. I'm going to keep going anyways. And there may be some times when that's what you have to do. But in thinking about the best way of treating a headache, recognizing that that's what's happening, that that's what's coming on, it's going to be much easier to treat at the beginning. In children in particular, over-the-counter medications are usually the first place that I go in terms of treating headache with medicines. So although there are migraine or headache-specific medications, broad studies show that over-the-counter medications are often really effective in children who have migraines. So starting with ibuprofen, acetaminophen, and naproxen are usually the first line if I'm thinking of a rescue medication or an acute headache medicine. Now, if you may have heard that these are medications that you should actually avoid in headaches. And let me just step back and explain where that might come from. These are really important rescue medications to be given for headache or for migraine, but for people who have chronic daily headaches, who are trying to treat every day, if you're taking ibuprofen, acetaminophen, naproxen, or other pain medications, you actually can get into a cycle where you have what we call medication overuse headaches. So these medications in particular, along with a handful of other pain medications, if you're using them continuously or daily, that can actually contribute to more headaches. So my recommendation is usually to avoid no more than 1 to 2 days per week. So you can dose them a second time the same day if they're not effective, if the first dose isn't effective in treating a medication, trying again 4 or 6 hours later. But to avoid the possibility of these contributing to headaches, try to keep them no more than 1 to 2 days per week. Okay, I have a little bit more on specific headache rescue plans, particularly for people who have migraines. This is something that's, I think, really hard for me to generalize, though. So the first line there is just discuss your headache rescue plan with your own doctor, because these can be very specific from person to person. I do want to bring up just a general point that some of the migraine treatments that are available are vasoactive. So not the ibuprofen, acetaminophen, naproxen, but some of the other medications, specifically triptans and ergotamines, can cause either vasoconstriction or avoidance of vasodilation. And so they have warnings for people who have cerebrovascular disease. And that includes aneurysms, or sometimes this says dolichoectatic. And what that means is just abnormal shape of your blood vessels and your brain that are commonly seen in kids who have face syndrome. So this is something that's probably going to be very important and very individualized. So very important that you speak with your own doctor, because you're going to have very individualized recommendations about what headache rescue medications that are migraine specific that might be good for your child. And this is where I often get into very individual risk benefit discussion, depending on what cerebrovascular anomaly looks like, and what we know about these psychoactive medications. And in some cases, for people who have very, very severe migraines, and one of these medications works really well, I'll talk about whether the risk benefit that, and it may be reasonable to accept an uncertain but a likely very small risk. I'd also like to spend a little bit of time talking about headache prevention. I alluded to this in some of my earlier slides, but one of the biggest, if we think about how to address headaches, I usually break it down into two categories. One is headache prevention. So if you are a person who has a tendency towards headaches or a tendency towards migraines, what are the things that you can do in your daily life to knock down that tendency to have headaches? And this can take some time in order to see a difference once you implement these interventions, but they can be really, really important part of headache management. So it's not just what do I do when I have a headache, but is how do I keep myself from getting into a headache cycle? The first thing I recommend is keeping a headache diary, and that's because what triggers a headache can be so individual for a person. And sometimes it's not something that you notice, especially as a child, until you see it happening a few times. So keeping that headache diary is really powerful, especially for kids who are getting into the 7, 10, 15 range, not maybe as much for the younger children who might have a little bit of a harder time describing it. But for as your kids are starting to get older, noticing what are the things that are the specific triggers? Was it that they went outside, had a huge soccer practice, and it was super, super bright, really sunny? Was it something that you smelled or ate? Was it emotional stress? Finding out what those headache patterns are can help you really address for an individual what are the specific things that that you can do to then also prevent headaches from happening. Because photophobia is so common, it's such a common trigger for headache, I always say that really simple interventions like wearing a hat or sunglasses when you know you're going out in bright sunlight, that can be a really important thing. And I know for myself, when I realized that bright light was a big problem for me, I began wearing sunglasses, and that made a huge difference for me. But I had spent so many years of my life without actually making that connection, that I can at least attest to, for at least one person as an individual, how much that should have been intuitive and was not. A regular sleep schedule. I recognize this can be really challenging for kids, especially in adolescence. But as much as we can try to promote healthy sleep and sleep hygiene, that can be something that is really powerful in terms of reducing headaches. Maintaining good hydration, avoid skipping meals. And then in some cases, recognizing that there can be really emotionally difficult times for kids in their life, and finding ways for stress management, overall well-being techniques, cognitive behavior therapies. Those can be things that actually really can make a big difference in managing headaches. And I bring this up in part because this is not something I think that is, again, always so intuitive, but it is such a large part of headache management that our headache center actually has 2 child psychologists who we've hired who will meet with kids and to go through a few sessions of cognitive behavioral therapy in order to help address ways that children can regulate their emotions and then also intervene to prevent headaches. So I can't stress that enough that is an important technique. Okay, so those are the non-pharmacologic ways of preventing headache cycles. Now, when should you ask your provider about daily medicines that can prevent headaches? So I had said before that I think of treating headaches in two categories. One is the prevention, one is the rescue. We've talked a little bit about the category of acute treatments to stop a headache once they've started. But many people don't know that there are certain medications that can help prevent headaches from happening. So I start thinking about those if headache episodes really frequently disrupt activities of daily life. And that can be, there's a little bit of a broad range there. Some people will say if once a week, for example, headaches are bad enough to interrupt your daily life, meaning they're leaving their classroom to go to the office and lie down, or they are playing and come to you and say, oh, they complain of their headache and they can't continue playing. So if it's interrupting your daily life regularly enough, for example, say once a week, that's kind of the time frame that I'm starting to think about. Maybe it's worth taking a daily medicine in order to prevent headaches. And I know that particularly with kids, daily medications are not a minor thing. And so there is sort of a level that I usually suggest reaching in terms of how frequent your headaches are before I suggest this. There are a broad range of medications that we know work in adults and not as many medications that have been tested in children. So when I start discussing headache prevention, knowing that the level of evidence for kids is a little bit lower, I usually start with the medications that we know that have been shown to be effective in adults and have very few adverse effects and have little risk. Those include vitamin B2 or riboflavin, melatonin, magnesium, and coenzyme Q. And I should say that among those, melatonin, people often recognize that because it's a really common intervention for sleep. But in this case, when I recommend melatonin, it is not specifically for sleep. It actually has been shown, again, in adults that even in people, even when sleep doesn't change, a treatment with a daily melatonin actually can reduce the number of migraines in people who have migraines. So I call those are the ones that I usually go to first because of their risk profile. When those aren't effective, it's important to know that there are other classes of medications that really can help reduce headaches when they're taken on a daily basis. There are a number of different ones. In general, the classes fall into medications that were originally developed to treat high blood pressure, to treat mood, or to treat epilepsy, and have also been found to be effective in reducing headaches. These work best with lifestyle modifications. So it is not that these are working in isolation. And as I'd mentioned before, this isn't something that's going to turn around really quickly. So anytime I'm talking about starting a medication or a vitamin to reduce the number of headaches that you have, I usually warn people that it's going to take somewhere between 6 and 8 weeks before you can really measure efficacy. And that's also where your headache diary comes in, because it's hard to know how effective these are if you're not comparing to what it was before you're taking them. And especially with children, it can be really hard to think back and say, wow, how bad were those headaches before? So being able to keep a headache diary, recognizing how bad they were, how often they were, and then 2 months down the line after making these interventions, that's going to be able to be what helps you decide, is this something that's useful? Because if it's not useful, then I usually don't recommend continuing any daily medication. So because I am a vascular neurologist and I do treat headaches, I often get questions about whether or not migraine is associated with stroke. And this is, I think, people's big fear. It's out in, been published, and so people hear about it a little bit. So what do we know about this? Most of the information we have, again, comes from adults rather than children. There is some of this published in children, but the basic evidence really is in adults. And we do know that adults with migraine have a slightly higher risk of stroke compared to people without migraine. And this is more important in the young adults rather than the elderly. That's at least where we see the effect more. And it is higher if the adults with migraine have other stroke risk factors. And specifically, smoking is an important one, and oral contraceptive use. But the odds, or how much does it increase their risk of stroke when you measure it, because it is primarily in young adults, even if it doubles the risk, which some studies would show that it may be on that order of doubling the risk, it still is an overall very, very small risk, because you're doubling a risk that's pretty small as a young person. We know that this association is probably, I said we know, we think that this association is probably limited to people or is driven by people who specifically have migraine with aura. And there is some thought that there are some mechanisms between aura and a little bit of a higher risk for stroke. What I tell the families that I take care of is that overall, stroke is a very, very rare event in children with migraine, and it's not something that I'm usually concerned about. So in one comparative study of an annual risk of children who are over 2 years old, so kind of the age that they can complain of headaches, there were 0.5 ischemic strokes per 100,000 children without headaches, and that risk was doubled, but that still only means there was one stroke, or doubled or quadrupled, depending on which one you look at, but still only 1 to 2 strokes per 100,000 children with migraine, so still very, very low risk. Now, I also often go over what are emergency symptoms, because children, even when I reassure people that migraine is not necessarily associated with a higher risk of stroke, the other thing that I commonly talk to families about or hear from families is that they are worried that even if they have a low risk of stroke at the beginning, how can I tell if this is a stroke or if this is a migraine? So how do I tell the difference between the two? When do I need to come into the emergency room? So I usually like to go over the emergency symptoms, and these are the things that suggest a more serious condition. So even if you are a person who has a migraine, if you have a very sudden onset headache that starts suddenly, a thunderclap headache, a headache that gets to be the worst over seconds, or the worst headache in your life, those are all things that you should probably come in and be evaluated for. That might mean that that you have a more serious condition. If you have a new headache or a headache, and there recently has been a trauma, a head injury, or a fall, those should be headaches that you take more seriously. They should have caution with. And then any headache that is, or severe headache that's associated with fever, stiff neck, rash, confusion, a new seizure, or stroke signs and symptoms of double vision, weakness, numbness, or difficulty speaking, those are emergency symptoms that you should have checked out. Now, I had mentioned earlier that people who have migraine with auras can sometimes have some of these associated symptoms. And if you are that person, you may commonly have those symptoms. And in those cases, I don't mean you have to get checked out every single time. However, until we can tell that this is a migraine with aura, that we have to know that this happens without a stroke a number of times. So if you have associated neurologic symptoms with your headache, it usually takes a little bit of time before we can be reassured that this is something that is truly your migraine with aura and not something more emergent. And then before I finish, just because I like to send people with some information to have that they can arm themselves with, these are some good headache resources that I like to point people to. They're all online. Hopefully everybody here on this online forum will have internet access so that they could look these up. But there are some good resources. The Headache Relief Guide is a website where you can actually go through with your older children and read about migraine with them. It comes with certain exercises. For example, like how much water should you be drinking per day? What is the kind of sleep that you should be getting? So that's a nice resource that you can use and that I think that older children could easily interact with. I would also point you to the American Migraine Foundation, and these two websites here are specifically about pediatric migraine, and then the second one is a patient guide for migraine, and that can be a good resource as well.